Welcome everyone to today's patient-focused webinar. I'm Michael Elias from the Swedish Neuroscience Institute, and I'm pleased to be part of today's virtual education event. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Tony Wang. Dr. Wang will be discussing focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise during the presentation, please utilize the Q&A button on your screen. We will have time after the presentation to answer all the questions asked within the chat. So let me please begin by introducing you to today's presenter, Dr. Tony Wang. Dr. Wang is a neurosurgeon at Swedish Neuroscience Institute here in Seattle, Washington. He's licensed to practice medicine in Washington, California, Alaska, Idaho, and Montana. Dr. Wang completed medical school at Wayne State University in Michigan, his neurosurgery residency at the University of Virginia, where he held the title of chief resident. It was during his residency that he was first introduced to using focused ultrasound to treat patients with essential tremor. Focused ultrasound gained its FDA approval from the pivotal trial that was conducted at the University of Virginia during his tenure. Dr. Wang then completed 2 fellowships, one in neurosurgery at Auckland City Hospital in Auckland, New Zealand, and the other from UCLA in stereotactic, functional, and epilepsy neurosurgery. Dr. Wang completed his education with many high-level awards and honors, so please welcome Dr. Tony Wang, and thank you for presenting this afternoon.
Michael, thank you for the very kind introduction. I just want to thank Michael and everyone behind the scenes for helping set this up, and thank you to all for taking a little time out of your day to listen to focused ultrasound. And so today's topic will be focused ultrasound for the treatment of Parkinson's as well as essential tremor. Just to highlight a little bit of my background that Michael already touched on, I am based here at Swedish Neuroscience Institute in Seattle. I conduct in-person visits here at our Seattle campus as well as Edmonds. As mentioned, I'm licensed to practice in addition to Washington, Alaska, Idaho, Montana, and California, meaning that I can see patients virtually. So if you happen to live in any of these states, I am able to conduct a telehealth encounter with you. As with any new emerging technology, folks are sometimes curious as to how many cases you've done. This is my background in training, as mentioned before. I've had a long experience with focused ultrasound dating back to 2013, dating all the way to present day. And you can see as we've kind of built up the program here in Seattle, we are nearing 30 cases here. Personally, I've done just under 100 of these ultrasound cases. And so, essential tremor goes by a lot of names. Some folks call it familial tremor. Some people call it idiopathic or even benign tremor. Okay. I know that a lot of people might call it benign essential tremor, but benign might connote that it's not serious or debilitating, but we do know that as tremor progresses, it can interfere with multiple activities of daily living. These activities we would qualify as, things like feeding yourself, drinking, writing, hygienic activities such as brushing your teeth or shaving. Currently, we don't know what the cause is. However, we do know that in many cases it can run in the family. So we will see a lot of patients and they'll say, actually thinking about it, my mom had this or my dad had this, or they'll tell us, what, my daughter or son is starting to get some tremor. In total, we know about 10 million patients have tremor. Patients, unfortunately, frequently live in the shadows with this tremor and frequently don't seek treatment. For those that do seek treatment, we know that medications alone do not adequately treat patients, and despite best medication therapy, many patients will still have tremor that bothers them, or intolerable side effects. And so here you see a little video of someone trying to drink, and now this person's writing, and you can see how tremulous they are. And this is a very common story that we see. So in terms of treatment options, the first line treatment for tremor would be medication. So frequently used medications to treat essential tremor would include propranolol. This also goes by the trade name of Inderal. So this is a beta blocker type medication, which is frequently used for blood pressure management. Another, what I would qualify as first line medication therapy, is a medicine called primidone. It also goes by its trade name Mysoline. This is actually an anti-seizure medication, which has actually found good use for treating essential tremor. In addition to these medications, there are some other medications such as anti-anxiety medications, or even other medications such as gabapentin, which can be second line medication therapies for essential tremor. Jumping to the bottom column, there's also wearable technologies. Many of you might be aware of a device called Cala-Trio. This is like a wristwatch type device that can help decrease your tremor. In the middle column, we look at surgical interventions. And so surgical interventions are considered when patients have tried medications and they either are not effective, or they're also causing debilitating side effects. And so there are a variety of surgical options offered for essential tremor. We're here to talk primarily about focused ultrasound. However, there's also deep brain stimulation, DBS, radiofrequency thalamotomy, and stereotactic radiosurgery, or also called gamma knife. Okay. It's important to remember that all of these surgeries treat the exact same area of the brain. Okay. The present day surgical treatment of tremor primarily circles around either DBS or focused ultrasound. All right. And so if we step back for a second, and essential tremor, while we don't know what causes it, we do know that, say, if you have really bad tremor in your right hand, there's a small area on the left side of your brain that is essentially overactive. The brain is crisscrossed, so the left brain controls the right body and vice versa. So in essential tremor, patients will have a small area of their brain, deep inside the brain, in an area called the thalamus that is overactive. So as I mentioned earlier, all these therapies target the exact same area, and how they work is that they effectively decrease the activity of this overactive area. When we think about overactivity in the brain, because this area of the brain is overactive, it then leads to these excessive movements, which are tremors. So take, for example, deep brain stimulation. We're not going to spend a lot of time on that today. For what it's worth, we do deep brain stimulation here, and it's a very effective and safe therapy. Deep brain stimulation involves an incision where we drill a hole in the skull and put a wire into the brain. That wire then runs underneath the skin to a battery that we put underneath the skin in the chest. So it's in many ways like a brain pacemaker. So this battery will send electrical stimulation up the wire down into the brain. And this electrode tip is at the overactive area of the brain. And what happens is electricity basically jams up the overactive signals, thereby reducing your tremor. All right. But, we're here to talk about focused ultrasound. So what's the deal with focused ultrasound? Focused ultrasound is a newer procedure. As I said before, it treats the exact same area of the brain that's overactive as, say, DBS. It just does it through a completely different manner. So, contrast to DBS, which uses electrical stimulation, ultrasound uses ultrasonic waves to heat this overactive area of the brain to burn it, then by decreasing your tremor. And so here I have a cartoon with a person with a magnifying glass. They focus the rays of the sun onto a paper. I did this when I was a kid, where I did it on a dry leaf, and then you burn a small hole in the leaf. Focused ultrasound is very analogous to this. So how this works is there's a helmet that's attached to your head, and within the helmet there are over 1,000 individual ultrasound beams that converge to a single point, and we can move this focus to the brain's overactive area and burn it, thereby reducing your tremor. The size of the burn we make is very small. It's about the size of a green pea. All right. Ultrasound, unlike DBS, however, you do not have to have many traditional aspects of surgery, right? We do not have to make an incision on your scalp. We do not have to drill a hole in your skull. We do not have to put a wire in your brain or a battery in your chest. All these waves can go through your scalp and through your skull into the brain and burn it, thereby decreasing your tremor. And so here is a depiction of a patient who had the ultrasound procedure before. These are her spiral drawings, and then after, you can see the vast improvement. Okay, so focused ultrasound has this benefit, say, over DBS, in which you don't have to have implanted hardware or anything like that. So here we have a kind of a video depicting how we do the procedure.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
All right, so that's a rough schematic of how the procedure is done. I'll go into a little bit more depth as to how we do this procedure. So these are some pictures that we've taken over the years of how this procedure is done. Here's a patient. They have a frame affixed to their head. I don't know if this comes across well, but this is the ultrasound helmet that your head goes into. You could see that the patient is on the MRI table, and the patient will slide in and out of the MRI tube during the treatment. And so this is a depiction of a patient being treated. The patient is awake during this time. Myself, the treatment team, we are on the computer workstation, and we can in real time monitor the temperature in your brain at the tremor spot. The benefit of you being awake is that during the procedure, we can test you to ensure that your tremor is progressively getting better. And so this procedure is split up into 4 phases that happen over the course of a couple hours. The first phase, or stage 1, includes a full head shave. After we shave your head, we place a halo frame device. It gets pinned to your skull at 4 spots, 2 right above your eyebrows and then 2 in the back here. I do want to be frank, in the approximately 100 cases I've done, it's on average that patients will say that the frame placement is perhaps the most unpleasant part of the whole experience. We will numb up your scalp with Novocaine type medication. However, that does sting briefly. And then once the frame gets placed, you will feel some tightness or some pressure. That tightness or pressure will subside in 5 to 10 minutes. Okay. The idea of the frame is that that frame will then secure to the ultrasound table itself, thereby rigidly holding your head in place. You can imagine if we're using ultrasound to try to burn a small area of your brain the size of a green pea, that we don't want your head to move even the slightest bit. So this frame is there for your benefit. So after the head is shaved and the frame is placed, we then move to the second phase right here. So Here we'll walk you into the MRI room, we'll get you on the MRI table, the frame will bolt to the MRI table, then fixing your head in place. We'll put some blankets on you because it's usually a little chilly. We'll get some padding, put some pillows underneath your knees and get you nice and comfortable. And then you slide into the MRI tube where you have a 20 to 25 minute MRI. So this portion of the procedure is not particularly interactive. You're welcome to close your eyes, have a snooze. We won't really be talking to you. After that 20 to 25 minute MRI, we then move on to stage 3 right here. So what we'll do is we will give you low doses of ultrasound energy. And the purpose of this is essentially target practice. So we want to give you low doses of ultrasound to ensure that the ultrasound device is going exactly where we tell the computer to go. We want to make sure things are accurate. So during this portion, you will hear the MRI machine make some humming noises, but you shouldn't really feel anything. Once the accuracy is confirmed, we start to increase the temperature. Okay, and so as we increase the temperature at the tremor spot, what we should see is tremor reduction. So with each successive treatment, we'll slide you out of the MRI table. I will then test your tremor. I'll ask you, you put your hand over your chest. I'll ask you to touch my finger and your nose, go back and forth. I'll stand over you with a clipboard and a piece of paper and give you a marker and ask you to draw spirals and lines. And so the idea of that is that we in real time, as that temperature increases, can see your tremor get better. And we can also monitor you for any sort of side effects. So once we've confirmed that we're in the right spot and that your tremor is better without side effects, we move on to the 4th and final stage where we further increase the temperature to seal in the burn, so to speak. With these higher temperature treatments, there's a couple things that patients will frequently report. They're going to say that they feel some sort of head warmth, perhaps head pain or discomfort briefly. Patients will also frequently say they feel a subjective sense of disequilibrium or that the room is tilting or spinning. So this has kind of come out in a variety of ways. So some patients have said that they feel like they are floating subjectively. Other times they've stated that they feel like their feet are flipping over their heads. Sometimes this can cause a little bit of nausea. We do give some medications before the procedure to combat this nausea feeling. Very, very rarely can cause things like vomiting. Those symptoms of head pain, headache, disequilibrium, nausea, those are just temporary during the ultrasound treatment itself. Each ultrasound treatment takes approximately 10 to 20 seconds in duration. Every patient's a little bit different, but in general, we see anywhere from 8 to 12 total ultrasound treatments. So when you add everything up, the amount of time that you are on the MRI table works out to be roughly anywhere between 2 to 3 hours. A lot of patients might have, some patients might have claustrophobia and they say, well, doc, am I going to be in this little tube for 2 to 3 hours? And the answer is no. Between adjustments and testing, we're sliding you in and out of that tube very frequently. I tell patients the longest uninterrupted time you're going to be in the little MRI tube works out to be about 20 to 25 minutes during stage 2, during this MRI right here. So once you have had the treatment that seals in the burn, we conclude the procedure. We detach the frame from the ultrasound table. We then remove the frame from your head. You go to recovery and then you're discharged home. So this is an outpatient procedure that doesn't require any sort of overnight hospitalization. And so what can you expect? And a lot of patients are, well, what's it going to be like? So the benefit in terms of tremor reduction is going to be immediate. So that is, the idea is that you come in, say on Friday morning, we do these procedures on Friday morning. By late Friday morning after the procedure, your tremor should be significantly better. So it's routine that we'll see patients in recovery. We hand them a glass of, some sort of fluid, and they're able to drink it with their right hand, where they previously weren't able to do that. We know that reducing your tremor is going to translate into significant improvement in the quality of your life. I touched upon this earlier, the idea that this is a benign tremor is perhaps a misnomer. We know that, people use their hands for everyday things, right? There are things that I do on my daily life that I take for granted because I don't have tremor. But, everyday tasks, all tasks are affected by tremor. And so when we reduce tremor, that naturally translates into a significant improvement in somebody's quality of life. As I mentioned earlier, it's an outpatient procedure. That is, you do not have to spend any sort of overnight stay in the hospital. As we're not cutting or making an incision, there's essentially little to no risk of infection. I think this is an important case to highlight because, for example, with DBS, you have to have an incision. We have to implant a foreign body in terms of electrodes and a battery in yourself. Again, that's a very effective therapy, but there are some folks who have tremor who have other medical conditions. Perhaps their diabetes is not well controlled, or they're on some medications that suppress their immune system. So I think, infection considerations are not insignificant. Again, you don't require any sort of device implant or any radiation. Radiation would be used for things like gamma knife thalamotomy. Again, this is not requiring any sort of anesthesia, and on the whole, complications are very minimal. I'll go into what those complications are in a couple slides. So who is a candidate? So in order to be a candidate for this procedure, you have to have either essential tremor or tremor-dominant Parkinson's disease. And moreover, you have to be medication refractory. So what that means is that you have to have trialed the medications, and either they don't work for you or they cause side effects that you find intolerable. Okay, you have to be above age 22 for ET, as well as age 30 for tremor-dominant Parkinson's disease. As I mentioned before, this procedure is performed with you awake, so we can monitor your tremor in real time during the procedure to make sure that your tremor is getting better. So given that you will be awake, you have to be able to tolerate the procedure without significant sedation, because sedation is very nice. It has applications. However, if we give too much sedation, then you can't communicate with us. And then moreover, with sedation, tremor frequently reduces. You have to be able to fit into the MRI scanner, right? So this procedure utilizes MRI. So you have to be able to fit into that small tube. So for some, heavier set people, 300-pound or plus, there could be concerns as to whether or not you would fit in that small tube that we use for the focused ultrasound procedure. There are some relative contraindications to this procedure if you have some sort of medical device. So I think the most common one we get asked about is pacemakers. A lot of the newer pacemakers that are placed for heart issues are MRI compatible, and more specifically are MRI compatible with the MRI that we use for this procedure. Some of the older pacemakers, and when I say older, these tend to have been placed, 10 or more years ago. Those tend to be not MRI compatible for this procedure. All right. The bottom line is if you have a pacemaker, myself and my team are more than happy to do a little investigation to figure out if your pacemaker is compatible with the MRI device that we use to perform this procedure here in Seattle. We've treated a number of patients with pacemakers using focused ultrasound with no difficulties or no damage to their pacemaker. There's also this idea of something called the skull density ratio. Okay, and so this isn't quite how thick your skull is. It's not quite how dense your skull is, even though it says density in the name, but it's a combination of the thickness of your skull as well as the density. And so patients need to have an appropriate skull density or SDR score in order to be candidates for this procedure. All right. Because the ultrasound passes through the scalp and the skull has to have the correct characteristics in order to allow ultrasound to pass through into the brain and make that small burn. In general, patients have to have a skull density score of greater than 0.4. That's probably an arbitrary number to you guys. You probably might not know what that means. So when I see patients in clinic, I put it in real terms for them. Essentially, of the patients that we see for evaluation for this treatment, roughly 80 to 85% of patients end up being candidates. That is, they have SDR scores that allow them to have this procedure. How we calculate the SDR is based off of a CAT scan of your head. So unfortunately, there is a small minority of patients that have disabling tremor who are otherwise good candidates for this procedure, who are interested in this procedure and want to have the procedure, but that cannot have the procedure because their skull has the inappropriate qualities to allow for this treatment. And so here we see another video. Here's two people pre and post ultrasound, just showing the change in how they drink a glass of water. And so that can be very profound. That's something that we routinely see after we treat patients here. And so I think, what are the side effects, right? I think that a lot of people, when they hear about ultrasound, they think, oh, well, ultrasound is what they use to look at babies and pregnant women, and there's no incision, and we don't have to drill a hole in your skull, so that means it's going to be riskless. Unfortunately, that's not the case. Focused ultrasound should still be viewed as a brain surgery. It's just a brain surgery that we perform without having to do an incision or drill a hole in your skull. All right. If you think about my example from earlier where I likened ultrasound to a magnifying glass that burns a small hole in the leaf, at the end of the day, we are burning a small area of your brain. And so when you think about it in that sense, yes, well, then there can be side effects. I will qualify this with that the vast majority of the side effects we see with focused ultrasound are temporary. Okay. It turns out that the tremor center in the brain is near some critical areas of the brain that are responsible for sensation in your body as well as movement in your body. So the left thalamus is responsible again for the right body. And so when we make this small burn in the tremor center, the body has this normal response to generate a small amount of swelling. That swelling can sometimes spill over to these other areas that are responsible for sensation as well as movement and cause very reliable and predictable side effects. So what we will tell patients when they come to see us for this treatment and have the treatment, we will tell them, after the procedure, you're going to likely see these side effects. And so that is numbness and tingling. So often we see it, let's say you're right-handed and we treat your right hand, you can expect to possibly see some numbness and tingling in your hand, possibly some numbness and tingling in the right side of your mouth, whether that be the lips or tongue. Sometimes that can cause a little bit of speech slurring, as well as some changes in your taste. And then also sometimes patients feel that they are a little bit wobbly after the procedure and that they're a little bit off balance. Okay. So again, those are very common. They happen anywhere from 20 to 30% of patients. However, I did mention that most of these side effects are temporary. What happens is beginning around 1 to 2 weeks after the procedure, the swelling around that little pea-sized burn starts to recede. And over the next weeks to months, as that swelling eventually goes away, a lot of these side effects will fade into the background or even completely go away. Okay. But again, we are burning a small area of your brain, so there is the possibility for a permanent neurologic side effect, which would namely be numbness, tingling, or potentially any sort of balance disturbance. In general, at the 1 year mark, I would say there's anywhere from 5 to 10% risk of that happening. However, most people, if and when they have a side effect after focused ultrasound, they do not find it particularly bothersome. So a frequent kind of story that we get told is that, we'll see someone in follow-up, they'll say, well, hey, doc, I'm really happy with this procedure. My tremor is gone. I can eat, I can drink, I'm writing, I'm going out to restaurants without embarrassment. And then I'll ask them about, side effects, and they'll say, well, yeah, I have a little bit of numbness here, or a little bit of numbness on my lip, or, when I get up, I got to be a little bit more careful. I just, I haven't fallen or anything. I just got to be a little bit more mindful. But I'm very happy to have had the procedure. I would gladly, trade tremor benefit and reduction for some non-bothersome side effects. All right. That's kind of the overwhelming story that we're told if and when patients have side effects. There are, bothersome, disabling side effects that can happen with ultrasound because, again, we are burning a small portion of your brain. Realistically speaking, the most likely disabling and permanent side effect that you could see would be a permanent worsening in your ability to walk. That can happen, but it's exceedingly rare. It's about less than 1% rate of happening. And so when we look at long-term follow-up, many of you might know that ultrasound is a relatively new procedure. It was FDA approved in 2016. So we don't have a lot of data to speak to the kind of, 10, 15-year outcome because it just doesn't exist. But the 5-year outcome does show that your tremor reduction is on average, 70 to 75% reduced. And so that does translate into a significant improvement in your quality of life. You're able to do what we call in the medical world activities of daily living. So these are tasks such as, dressing yourself, eating, drinking, writing, using the computer, using your smartphone. In addition, a lot of patients that we see with essential tremor are embarrassed by the tremor. And so after the tremor reduction, they no longer have this, embarrassment associated with tremor. They're able to, go back to work. They can enjoy hobbies and, leisure activities. So, the benefits for reducing your tremor are very widespread. In terms of, where our focused ultrasound centers, I am here in Seattle. Swedish is the only institution in Washington with this technology. There's one other treatment facility in the Pacific Northwest down in Portland. We see patients from not only all over Washington, but from the Pacific Northwest in general. We've treated patients from Oregon, Idaho. We're seeing patients from Alaska. We've even had patients come as far as Phoenix to Seattle specifically for this procedure. This being a newer procedure, patients are often curious about insurance coverage. I will be frank with you that, when I first started doing this many years ago, there were some insurance issues in that some insurance didn't cover this. This has improved tremendously over the past few years to where it's Medicare approved in all 50 states. Some of the private insurances still, we do see some, insurance pushback. However, again, this is becoming less and less of an issue than it was, say, even 1, 2, 3 years ago. Here we have a video highlighting a patient that we treated here at Seattle with focused ultrasound about a year or two ago. So I'll just play this and have him tell you his story.
Bill Bezanson. I'm 76 years old. I'm here to talk about the surgery, the brain surgery that was done for me at Providence to stop the essential tremor that I had that was taking over my life.
What does it mean to be healthy?
Ooh, that's a good question. I think that just means being able to do the things you want to do in life without, pain, disability, or difficulty.
A year and a half before I had the surgery done, I started noticing little shakes in my hand. They started to interfere with cooking. All of a sudden I'd splash myself. I couldn't eat soup and I couldn't eat cereal. Well, it got worse. It got to the point where I couldn't even use my right hand.
Ultrasound has been used in neurosurgery for a long time, actually. And then in the early 2000s, there were some developments in kind of the physics side of ultrasound that enabled physicians to deliver ultrasound through the skull without removing any sort of portion of the skull. And so that made it very attractive.
Everything that you do with your right hand, if you're right-handed, everything was affected. It's embarrassing to get a glass of water from somebody and you spill it, and you automatically reach for your right hand because you're right-handed. Just imagine if your hand shakes and you can't control it, and that's what it was.
A lot of these folks, when they start, they can't even get the pen to the paper. They'll just kind of tremor kind of like this and not be able to draw a nice smooth spiral. We always start with a kind of a before, where we get kind of a baseline, and as we give more and more ultrasound, we continue to test them, and you'll see this slow kind of incremental improvement in their tremor, which signifies that we're in that correct spot. And then once we're there, we give more energy to kind of seal on the burn. So that whole procedure lasts about 2.5 to 3 hours.
I knew at that moment, the moment I drew the spiral correctly, that it was over with. It's an awfully good feeling.
We'll see patients in follow-up at 3 months and a year, and it's always great to check in with patients and see what they're able to do, and they are often excited to tell you what they're now able to do. I think that's important.
This was an example of my spirals before, and number 7, they're beginning to improve. And this is when they dropped me out after everything was done. The spirals are spirals. There's quite a difference. This was done this morning. So, no shakes. I'm so pleased, I can't tell you.
There was an example of a lady who had this procedure done, and she sent us in like kind of a stitch work of what she was able to now do. And so that's kind of the best day I could have, where you're able to perform a procedure which has an immense positive effect on someone's life.
Can you sign your name for me?
That's something I was never able to do. I just feel appreciation for being able to write again, to sign checks again. I feel human again.
All right, so that was a very powerful story from Bill. This is a story that's pretty common. I'll be honest with you. After folks have this procedure, right? He's talking about kind of, again, these activities of daily living, right? He says that, I can't cook. I have trouble, reaching for a glass and drinking, signing my name. All of these things have been improved after this procedure. And so now, I'll open up the forum to some question and answer. I'll be happy to answer any of the questions placed into the Q&A chat box. I will just leave up some contact information for those who are interested, who want to contact us and discuss more.
Great. Dr. Wang, the first question that's coming in is, one, will the attendees get a copy of the presentation afterwards?
Yeah. Michael, I think this is being taped, correct? And so that the patient should have access to this, correct?
Correct. Yeah. Anyone who signed up and registered for the presentation will be emailed a copy of the whole presentation. So yes, you'll have access to all the information.
Okay.
The next question is, are all the treatments administered in a single visit?
Yeah, that's a great question. So this is an outpatient procedure, so it doesn't require any sort of hospitalization. But, in order to be, deemed a candidate, you would first have to, either come to Seattle or Edmonds to see us, or, we could Zoom with you. While it is an outpatient procedure, I will tell patients it's actually a 3-day affair. And so what I mean by that is we perform the procedures on a Friday, either Friday morning or Friday afternoon, depending on how many cases there are that day. The day prior, on Thursday, you come to the hospital for an outpatient MRI. This is the normal MRI that lasts about 40 to 45 minutes. Okay, so that's an outpatient MRI. So Thursday, come in for the MRI, outpatient. Friday, return for the treatment, which is also outpatient. And then we bring you back Saturday for a post-ultrasound MRI. Okay, depending on where you live, if you live kind of far away and you need to catch a flight or sometimes flight to somewhere, we have done those MRIs on late Friday afternoon, early Friday evening to allow you to return to where you live on Saturday.
The next question is, after the treatment, are follow-up treatments required?
So we will call you 2 weeks after the procedure just to check in. Like I said, after the treatment, you might have some of these common side effects, and at 2 weeks we will call you. I then will either see you in person or Zoom with you around 3 months after the procedure to just check in and see how you're doing. And then I like to see patients at 1 year after ultrasound just to make sure things are going well.
Okay, the next question is, if the procedure damages a small portion of the brain, are there other functions that might be compromised?
That's a great question. So as the overactive tremor spot in the thalamus is close to areas of the brain that are responsible for sensation as well as movement. Okay, so the burn could, the swelling associated with the burn could bleed into these other areas that are responsible for sensation as well as strength. So that's why patients who have this procedure might expect to have numbness or tingling in the hand that we treat, as well as the lip and tongue. Sometimes that can cause a little bit of speech slurring or alterations in your sense of taste, as well as some balance difficulty. Okay. Most times these side effects will go away. However, again, we are burning a small portion of your brain. So there is a possibility that these side effects don't go away. In general, that's unlikely to happen. Permanent side effects at 1 year are around 5 to 10%. Moreover, most patients are not particularly bothered by these side effects if and when they happen. So I mentioned earlier, a lot of patients will come to us and say, if they have a side effect, they will say, my tremor is doing really well. I have some non-bothersome numbness. I'm not perturbed by this. I'm very happy to add the procedure. Realistically speaking, the worst case scenario that can happen with a focused ultrasound would be a permanent and disabling worsening in your ability to walk. So that is, you might need to use a walker or a cane after the procedure where you previously weren't, right? That can happen. Again, it's very rare. It happens with the likelihood of less than 1%.
The next question is, there was some confusion about if essential tremor is linked to Parkinson's because it's the same target for tremor.
Yeah, so that's a great question. Essential tremor and Parkinson's, I colloquially like to refer to them as perhaps distant cousins. We do see that they are kind of on the spectrum. I'm not here to in any way suggest that if you have essential tremor, you will then get Parkinson's disease. That is not what I'm saying at all. But there are a small number of patients who do have essential tremor, and then as they age, they can develop Parkinson's. Yes, you are correct. The same area of the brain is targeted for both of these diseases, essential tremor and Parkinson's. For Parkinson's, though, you have to have a certain subset of Parkinson's disease, which is tremor-dominant Parkinson's disease. So for those with Parkinson's, you will know that, Parkinson's disease typically isn't just tremor. There are other symptoms that go along with this. This includes stiffness, slow movement, rigidity, or dyskinesia. The procedure that we described would not treat any of those symptoms, but only the tremor involved in Parkinson's.
Great. The next question, or additional question, would be how severe should it be before considering this procedure?
Yeah, that's a great question. There's no easy answer to that because tremor is a very subjective thing, right? You as the patient, you're the only person who knows how bothersome tremor is to you because you're the only person that deals with it, right? Let's say, you have a 90-year-old who doesn't really do much. They have a really bad tremor, but if they're really not doing much and perhaps they have a lot of medical issues and they're bedbound, perhaps a really bad tremor doesn't affect them. Conversely, let's say you're, younger, 50 or 60, and you're still working, let's say you do a job that requires, dexterity, like say you're a dentist, right? Or something like that, or a watchmaker, right? That's perhaps an extreme example, but you could have a much smaller tremor that you find very bothersome. In general, to be classified as a candidate for this procedure, you have to have disabling tremor that is medication refractory. There's no hard and fast rule that it has to be a certain grade or, it has to be this big or, this big. Certainly those things help us as clinicians kind of, stratify you as to how much tremor benefit you're going to see. But all it has to be is refractory to medications and disabling to you. Those are the conditions that need to be met in order to kind of explore any sort of surgical option for tremor.
Okay. Can you also address the typical ages that we've done patients?
Yeah, so I would say the youngest person we have done recently was probably in their 40s or 50s. More frequently, we see folks in their kind of 70s to 80s.
Okay, great. I think our oldest was 91 at one point.
Sure. Yep.
Another question is this covered by insurance?
Yes. So it is approved by Medicare in all 50 states. When I started this many years ago, insurance gave some pushback on this. As it's gained more and more acceptance and there's been more and more literature pointing to the efficacy as well as safety of this procedure, we've seen insurance be more and more accepting of this. I will say, however, that there, depending on your private insurance, there can be some instances where insurance puts up some sort of resistance to this. However, this is becoming less and less as the years go by.
Great. Now the question is, does your primary care doctor diagnose essential tremor and start you on Inderal, or do you need to see a neurologist or a neurosurgeon?
Yeah, that's a great question. I think there's been this traditional thought that, essential tremor needs to be diagnosed and treated with medication by neurologists. However, we have seen, and I have seen patients referred here who have been diagnosed by their primary care, and their primary cares are very, good, and they have started all the correct medication. So it is, for us to, have a visit and chat about ultrasound is not a prerequisite that you have necessarily seen a neurologist. This is a fairly common disease. As mentioned, 10 million Americans have this. So, primary care doctors frequently are kind of the first go-to for diagnosis and treatment of this.
Great. Next question is, does this help head tremor?
Great question. So, essential tremor, there's kind of different flavors of tremor, right? So, frequently it's in the hands and arms, but we know that essential tremor can also present in the head as well as the voice. So there may be folks on this call who have a head tremor as well as a shaky voice. In general, the midline tremor, so tremor in like kind of the middle of your body, so head tremor, voice tremor, in general, we feel that responds best to treating both sides of the brain. Because, when you think about it, when you make spoken speech, you have vocal cords that are on both sides. And so when you have vocal tremor, both of those are tremoring, right? So I tell patients when they're looking at this procedure that, if you have some head tremor or voice tremor, it shouldn't really get better after just treating one side of your brain for, say, just your right hand. However, while I do tell that to people, I know for a fact that a lot of patients that we've treated recently, they come back to us and they tell us, hey, doc, you told me that my head tremor wasn't going to get better, or my voice tremor wasn't going to get better. My hand tremor is good, and my voice tremor or my head tremor is better. So the official kind of party line is, I will tell you that don't expect it to get better. But however, in the past year, we have seen many patients self-report that their head as well as voice tremor gets better with just treating one side.
And then that leads into the second question is, how soon can you get the second side done?
Great question. So for a long time, there was thought that if you burn or lesion both sides of the brain, that you would have higher rates of side effects. So this would be speech, swallowing, balance difficulties. I want to be frank with you. A lot of this data was kind of based on some older, shall we say, more archaic methods of burning the brain. So this is where they would put a probe in your brain and then use radio waves to burn it, okay? So for a long time, folks thought that ultrasound should only be used on one side of the brain. However, with advances in technology, namely, the precision of the device itself, the fact that we use MRI in real time to, guide the targeting and the size of the lesion, we're much more accurate than we were back, 3 decades ago when they were doing all these studies on the older forms of burning. So recently, the FDA did approve patients to have both sides of their brain treated to treat both, say, their right hand and their left hand. The FDA mandates that patients wait at least 9 months between treatment of their first hand and the second hand. Moreover, if we're evaluating you for treatment of the second side, we want to make sure a few additional conditions are satisfied. First, we want to make sure that you had good clinical benefit with the first treatment and that you don't have any significant side effects as well. Other questions, Martha?
Yes, the next question is, one of our audience members had read something about stiffness being helped with focus ultrasound. I think they're talking about the PD-006 trial that was done.
Sure. So as I mentioned earlier, Parkinson's disease isn't just tremor. So there are other symptoms associated with Parkinson's disease, namely stiffness, slowness of movement, dyskinesia. The talk for today was specifically, targeted for ultrasound for tremor. the target that we're talking about where we make that pea-sized burn wouldn't help with stiffness. However, there are other areas of the brain that we can ablate or burn that aren't for tremor that can help with symptoms of stiffness, slowness of movement, as well as dyskinesia in Parkinson's disease. To be clear, that is FDA approved, okay? However, unlike ultrasound for tremor, ultrasound for, say, stiffness, slowness of movement, or dyskinesia is not currently approved by insurance. Okay, so that I think is a fairly important distinction. And moreover, ultrasound for treatment of stiffness, slowness of movement, and dyskinesia is not approved to treat both sides of your brain. So you can only have it on one side of your brain, and you will not, as of me talking right now, have any sort of insurance pay for that procedure. Ultrasound for tremor, however, does have wide insurance support and approval.
Next question is, in the decade since 2013, the initial investigation of focused ultrasound, have there been any other progress in any other treatments? In other words, what other treatments are emerging?
Sure, in terms of
treating tremor.
Treating tremor, well, I would say this is kind of the newest kid on the block, so to speak. There have been, maybe this is an answer to your question, but there have been kind of advances in how we do this procedure. We've learned a lot as to minimize side effects. We have better imaging to help us see where those critical areas are around the tremor spot as to not damage them. In terms of any sort of new medications, there haven't been really any new medications. Since 2013, DBS has been around for a long time for tremor. It's been FDA approved since the late 1990s for the treatment of essential tremor. Since 2013, there have been some advances in, I'll be frank with you, fairly significant advances in DBS, in that we have many more programming capabilities than we did, say, a decade ago.
Okay. Next question is, one of the audience members had gamma knife surgery for their left-hand tremors. Can they have ultrasound for the right hand?
Yeah, excellent question. That is someone, we've seen that patient described. I've seen that patient, perhaps not you, but that scenario I have seen. Provided that you do not have any significant or noticeable side effects following the gamma knife, there would be no, concerns from my part to have the other side of your brain treated with focused ultrasound. Recall that, at present, focused ultrasound does have approval to treat both sides of your brain.
Back to a medication question is, how long does one have to take medication to know if it will treat the issue?
Great question. So typically speaking, I would say probably a couple months or something like that. If, however, you trial, the first line medications and you have really bad side effects that develop immediately, then I wouldn't, want you to take medications for months on end with you having bad side effects. But, for these medications, propranolol and primidone, I would say if you're not having any sort of significant side effects, generally speaking, I think at minimum, you would want to trial at least a couple months to make sure you can get up to a high enough dose to see if it helps at all.
Great. Next question is, I am right-handed and have tremors in both right and left hands and my head. Are all areas treated?
Great question. So if you're right-handed, the overwhelming majority of right-handed patients, we would treat the left brain first, and vice versa. If you're left-handed, we would likely treat the right hand first, or right side of your brain first. The ultrasound procedure would help with your right hand. It may or may not help with your head tremor. The traditional teaching is that, if you only treat one side, it's not going to help the middle of the body tremor. But sometimes we do see that, just treating one side of the body, one side of the brain will help with the head and neck tremor. If we only treat the left side of your brain, we would not expect any sort of improvement in your left hand tremor. So in order to address your left hand, you would then have to come back at some point to have some sort of treatment on the right side of your brain.
Would an implanted titanium plate prevent an MRI?
So, without knowing which one, I can't say definitively, but I would say more than likely not. We used to think that, people who have had brain surgery in the past, when they put the titanium mini plates and screws are contraindicated from having this procedure, and that's not the case. So more likely than not, if you have a small titanium plate that was, I presume placed by a surgeon, that more than likely is going to be MRI compatible and not preclude you from having this procedure.
We have a great question here. It's, can you take a bathroom break during the MRI?
Excellent question. So the procedure lasts about, you're going to be on, the table for 2 to 3 hours. We've had patients handle this a variety of ways. We will ask you, when we shave your head and right before we're going to put the frame on, we ask you to use the bathroom. So some patients, go through the procedure without any sort of, bathroom break. Other patients, if they're having, concerns about it, we can put some sort of catheter in beforehand to, obviate the need for some sort of bathroom break during the procedure. We have also seen patients who don't have a catheter during the procedure, and then during the procedure they say, well, I need to use the restroom, and there we have a very experienced nursing team who can help provide you with a bathroom break while on the MRI table.
We have a lot more patients still asking about head tremors. Seems like it's a popular question. How about talking about the essential tremor, head tremor versus potentially a dystonic tremor, and how patients can get diagnosed with that?
Yeah, so the head tremor is very common in essential tremor. The kind of the old school teaching would be that you have to treat both the left and right side of your brain in order to treat tremor in the middle of the body, whether that be through deep brain stimulation on both sides of the brain or bilateral focused ultrasound. We have, in just our own anecdotal experience, however, noticed that even with treatment of one side, patients can see improvement in their head and neck tremor, perhaps not, resolution, but certainly they can see potential improvement.
If a patient had dystonic neck tremor, would you expect this focused ultrasound to help them?
Well, if you have dystonia, that might be something else. That I'm not saying that, whoever asked this question has Parkinson's, but, if you have some sort of dystonia, that might not be, essential tremor. So whether or not that would help is hard to say.
Okay.
I see one additional question. It says, if you have completed 100 procedures, then have 25 not been successful? So that's a great question. I just want to expand upon that. The 5-year data says it's a 75% tremor reduction. That doesn't mean that 75% of the patients had tremor reduction. That means on average, we score your tremor and give it a score. That means your score has reduced 75%. So that doesn't say that for every 4 patients, only 3 patients are going to see tremor benefit. That means that for every 4 patients we treat, on average, all 4 patients are going to see tremor reduction, and that the tremor reduction is going to be 75%. So there's a little bit of a nuance there, but I just wanted to highlight that difference.
We have another patient saying, I had laser surgery 12 years ago that put my trigeminal neuralgia into remission. I've had familial and essential tremor longer than that, and I'm very, very interested in the focused ultrasound to treat the tremor. My concern is that the procedure could set off my trigeminal neuralgia again.
Yeah, I haven't heard of trigeminal neuralgia getting flared up by this procedure. The trigeminal nerve is not near where we target for focused ultrasound. So while I can't, with 100% rule that out, I struggle to see how this procedure could set off trigeminal neuralgia if you've been pain-free for many years now.
Great. We have another patient asking, can we do the focused ultrasound if there are stents from an aneurysm, a brain aneurysm?
Yeah, provided those stents are MRI compatible, I wouldn't see any contraindication to that.
Another question is, I've heard the effects will last 3 to 4 years. Then what? Can you do it again?
So great question. The procedure was approved in 2016. So, we don't know, let's say, the decade-long results. So, it is possible at 3 to 4 to 5 years that you might see a little bit of tremor recurrence. If that is the case, you're still going to be much better than where you started, and this can be repeated. So I want, some people have the conception that, once you have focused ultrasound, that bridge has been burned. You can no longer have anything else ever done again. Ultrasound can be repeated. Moreover, if you have ultrasound and if, let's say, the tremor comes back at some point, and you want to have deep brain stimulation, you can also have that as well. So having ultrasound doesn't, eliminate any sort of future options.
Great. We have one more patient saying he had a bilateral thalamotomy at Northwest Hospital in 2013, 100% recovery in the right hand, 85% in the left hand. But this year his tremors are getting worse on his left side. Can he have this procedure?
Yeah, so possibly, I think that's a very interesting case. We would want to, get an updated MRI of your brain to look at that. But, based on that short blurb, that wouldn't, in my eyes, rule out a potential ultrasound treatment.
We have another patient asking, how far out are we scheduling now?
Yeah, so we are scheduling out into, I believe, January 2024 as of right now. Perhaps maybe even reaching into February right now, but last I heard it was January. I do know that, we have cases later this week in November as well as December.
And another question is, how far in advance do you have the CAT scan for the skull evaluation?
You can have that anywhere along the, the time course of evaluation. It doesn't have to be, like the day before. Usually we just, if you come see us and we feel you're a good candidate and you're interested in the procedure, we will just order a CT scan and then go from there.
And we have another question on dystonia. Is there research being done on this treatment for tremor related to dystonia, cervical or foot?
So as I mentioned earlier, if you have dystonic tremor, there have been reports that this technology has been used to treat dystonic tremor. I will be frank with you, it is not to the degree that essential tremor has been investigated. So, but with that said, there have been published reports in the medical literature that patients with kind of dystonic tremor have been successfully treated with this procedure.
And how soon can I have focused ultrasound on the other side of my brain?
Yeah, so it's 9 months between your first hand and your second hand. So say if you have, the procedure in January, then the soonest you could have your other hand treated would be September.
Another patient said they have an Inspire implant for obstructive sleep apnea. They can't have an MRI of the chest or abdomen, but they were told a brain MRI would be okay. Have we performed this on a patient?
We haven't performed this procedure in someone with Inspire implant. I am familiar with what that is. If you were interested in this, we would have to, consult with our radiology department to figure out if your device is compatible with the MRI that we use for this procedure.
Next question is there an evaluation to see if someone is bad enough to do this? He is a professional photographer.
Yeah, so we evaluate people in person at our Seattle campus as well as Edmonds, Washington campus, and we can also evaluate you virtually, provided you reside somewhere in Washington, Alaska, Idaho, Montana, or California. I can then legally interface with you via telehealth.
Is there any advantage to doing the procedure before the tremor worsens?
So that's a great question. So, sometimes people will come to our clinic and they say they have tremor and they'll say, well, doc, should I have this procedure or not? And, that's a very hard question for me to answer, right? I'm not here to sound flippant or dismissive of tremor at all. I know tremor can be very debilitating and affect your quality of life negatively. However, we do still view all of these procedures for tremor as elective, right? Again, at the risk of sounding crass, tremor is not viewed, say, as brain cancer is, right? So if you have brain cancer, I think most people would agree, you probably need to have an operation pretty soon. For tremor, it's much more nuanced, right? As I said earlier, you as the patient, you're the only one with tremor. You are the only one who knows how bothersome the tremor is, right? Only you can make a decision as to whether or not you feel your tremor is bad enough to warrant having a procedure that does have potential risk.
And a follow-up question on that is if someone who doesn't require medication yet, but the tremor is worsening, is this appropriate for them?
Yeah, I would say if you don't require medication or you're not on medication, then you would not be a candidate for this procedure, right? As I said before, this procedure, even though we don't cut you open with a knife or drill a hole in your skull, should still be viewed as a surgery. And this surgery, as with any other surgery that's offered in medicine, has risk with it, right? And so when we are thinking about when to offer these surgical interventions for something that is ultimately elective, we want to make sure that you've trialed things, before surgery, such as medication, right? So it would not be of standard clinical practice to offer this procedure if you haven't trialed medications first. Moreover, on a more kind of real world logistical concern, if you have not trialed medications, you cannot be thus qualified as being medication refractory. And that's important because insurance will not cover this procedure if you are not classified as being medication refractory.
Great answer. Next question is, do you need a driver after treatment?
Yeah, so we advise that you have someone drive you to and from the procedure. Again, we're not cutting you open or anything like that. You're not getting any sort of anesthesia, but you will feel a little just kind of patients feel a little kind of tired from the procedure, a little, just it can be a little bit of a stressful day, right? Because you're having this procedure that's brand new to you. As much as we counsel you as to what to expect, it can be very nerve-wracking. You're just going to feel a little bit run down after the procedure. So we don't expect you or really want you to drive. So we have patients' families handle that for them after the procedure.
Next question is this a permanent solution?
So great question. So neither of these, neither focused ultrasound nor deep brain stimulation should be viewed as a cure for your essential tremor. I'm sure a lot of you on this call have noticed that as the years have gone by, your tremor has gotten worse. And so regardless of which procedure you have, it is possible that, in the future, your tremor could come back or worsen a little bit. The studies looking at focused ultrasound show that, at 5 years, there's probably a little bit of tremor that's come back. Be that as it may, you're still at a much better state than where you started before the ultrasound, right? I can't really speak to, longer outcome than that, because ultrasound has not, it hasn't been around long enough for folks to kind of know what, like, say, the 10-year outcome is. But with that said, if you have the procedure and your tremor does come back, you can have this procedure repeated, and you can also, if you are interested and want to, have deep brain stimulation as well.
So I'm looking through some more of the questions here. Oh, you mentioned a full head shave. Do you offer wigs for patients?
So great question. We ourselves do not have a wig making service. In the various places that I've done this, and this, for what it's worth, does tend to be more of an issue for women. Women sometimes will, like, kind of in the preamble to this, arrange to have a wig made so that after, the procedure, they can slap on a wig and no one will be the wiser.
Great. Another question on, can it work for tremor in your jaw?
Again, that would kind of fall into this head neck tremor. Typically I would say no, but our own anecdotal experiences has indicated perhaps otherwise.
Now the question is, people with multiple sclerosis have brain lesions already. Would this impede the focused ultrasound treatment?
It wouldn't. It shouldn't. I do know that multiple sclerosis patients can sometimes have tremor. This has not been studied to the degree, this being ultrasound, has not been studied to the degree that essential tremor has been. So whether or not this would definitively improve a tremor with multiple sclerosis, I don't know if your tremor is due to multiple sclerosis or you have multiple sclerosis and essential tremor. But if your tremor is just due to multiple sclerosis, I don't, it hasn't been studied to the degree that it has been for essential tremor.
Another question is, I had a successful focus ultrasound to the right body at OHSU. Can I have the left side done at Providence Swedish?
Yeah, provided you don't have any side effects and you've gone 9 months in between your treatments, yeah, that would be okay.
And are outcomes improved if the procedure is done as soon as possible instead of waiting until the tremor is more disabling?
Well, that speaks to kind of my point earlier about, when should you have this? And, I'm not trying to be intentionally vague, but that's a question that we as, medical providers can't really answer, right? At the end of the day, these are elective procedures, right? These procedures carry with it risk. Only you as the patient know, like, how bothersome the tremor is to decide to have a procedure that can have risk. Whether that's going to be, now when the tremor's less, but you're more active, or later when you're older, perhaps not active, but your tremor's worse, it is really hard for me to say.
Next question is, how soon can we get an appointment?
That's a great question. On this contact, slide we have up, you can, email us or phone us. We're always keen to see tremor patients as soon as possible. So, you can contact us and we'll get you in as soon as possible.
So here's a good question that kind of goes on how bad does a tremor need to be for disabling, that more of an example. So we have somebody who can't use chopsticks, longhand writing is not good, but they're not on medication. So are they a candidate? The primary care says it's mild essential tremor, but these effects are definitely noticeable.
Yeah, so, unfortunately, if you have tremor and you're not on medication, then you wouldn't be a candidate, because in order to have this procedure, you have to be classified as being medication refractory. So what that means is you have trialed medication and then the medication doesn't work, or you've trialed medication and you have disabling side effects that prevent you from taking medication, right?
Next question is, I have a Watchman in my heart, left atrial appendage occlusion. Will that be okay for the MRIs?
Great question. We haven't treated someone with a Watchman to date. I know what those are. We could, we'd have to gather information about your, the kind of the make model of your device and run it by our MRI department to see if it's compatible with the MRI scanner that we use for this procedure.
Okay, looking up another patient's. We will be sending out, just for a reminder, we will be sending out the recorded video of this to everybody that's here. That question has been coming up a lot. Is it mandatory to shave the head, or is there an alternative?
Unfortunately, it is. Despite all the technological advances that have been made that allow us to deliver ultrasound into the brain itself without, drilling a hole into your skull, we still have to shave your head. So.
Next question is, are you the only one doing this procedure locally?
We are the only facility in Washington that offers this procedure.
Just to add on to that, there's one other surgeon from Evergreen. I've had 3 questions about that already. If we are doing the same procedure that the Evergreen neurosurgeon who is using our facility does.
Yeah, to be clear, he does those procedures here at this institution. So.
Next question is, does Botox help head tremors?
Botox does help with head tremors. That is something that we see not infrequently for folks who have head tremor.
And a follow-up question on where to get this done is this done anywhere else in the world?
So there are multiple centers now across the United States that do this. We are the only facility in Washington that offers this procedure. We've had extensive experience here at Swedish, dating back to kind of the investigatory studies looking into this. But it is offered in many countries. Off the top of my head, I know they have them in Canada, obviously here in the United States, Japan, Australia, as well as numerous countries in Europe as well as Asia.
And Israel.
And Israel, of course.
Yes. Really started it. The next question is DBS a better alternative for head tremor?
Yeah, I would say maybe the traditional thinking would say yes, because you need to have both sides of your body treated in order to treat the kind of the middle of the body tremor. But with that said, there have been small published reports that state after treating both sides of your head with focused ultrasound, there have been significant head and neck tremor improvements. Moreover, Martha can attest to this. There have been patients that we've treated just one side of their brain just to treat their right hand, in which we told them, hey, your head tremor is probably not going to get better, but then they come back and see us and follow up and say, actually, my head tremor is better. So.
Okay. We have somebody saying, you have done 97 procedures. My family's in the Portland area. How many procedures has the Portland site done?
Yeah, I'm not here to, I don't know. I don't work down there. I'm not here to speak ill of the neurosurgeons in Portland that have a very good, facility down there. I do know that they got their ultrasound machine relatively recently. I think it was about 1.5 years ago. I can't speak to how many procedures they've done. As mentioned, as an institution here at Swedish, we've had the focused ultrasound almost a decade. Myself, I've had, experience and exposure with this technology dating back to 2013. So, but I can't speak to how many procedures they've done down in OHSU.
Okay, it looks like mainly the rest of the questions are about if both sides of your body can be treated, which you've answered 9 months in between each side. A lot of people asking about the mandatory head shave.
Yeah, sorry about that. That unfortunately has to be done.
And a lot of people asking about whether this event will be published on YouTube and also about the video links to the recorded afterwards.
Okay. Well, Michael, I think we've answered all the questions here.
Yeah, thank you so much, Martha, for your help with all of the questions. And thank you, Dr. Wang, so much for such a great presentation.
Absolutely, you're very welcome.
If anyone else has any further questions, feel free to email us at swedishfus@swedish.org or give us a call at 206-320-4145. And like Martha was mentioning, the video recording will be sent out to everyone next week. So please be on the lookout for that next week. And we hope that everyone has a great day. And thank you for joining today. Bye now.
Thanks a lot.
Thanks, Michael. Take care, everyone.